Hello and namaste to everyone. This is Jayoti Singh from Department of Physiotherapy and Diagnostics from Jayoti Vidyapeeth Women's University. For today's session, I'll be talking about metabolic alkalosis. So, first of all, in earlier sections, I've already talked about metabolic acidosis and the disturbances of acid-base balance. So just to revise, there were two types of acid-base balance disturbances, and one of them is acidosis, and the other one is alkalosis. Now, what is acidosis basically? In case of acidosis, there is decrease in pH below the physiological range, that is below 7.38, and in case of alkalosis, pH goes above 7.42, right? So acidosis, there is a fall in pH, and in alkalosis, there is rise in pH. Acidosis, it is further of two types, respiratory acidosis and metabolic acidosis. For respiratory acidosis, there is excess of carbonic acid. In case of metabolic acidosis, there is primary deficit of bicarbonate. Now, in case of alkalosis, there is rise in pH. So, respiratory alkalosis is deficit of carbonic acid, whereas in case of metabolic alkalosis, there is excess of carbohydrate. So, in our last session, I have told you in details about metabolic acidosis and anion gap. And I've also talked about high anion gap metabolic acidosis and normal anion gap metabolic acidosis. Now, further, let's talk about alkalosis. So, next we'll be talking about metabolic alkalosis. So, what is metabolic alkalosis? Basically, there is primary excess of bicarbonate, and which is the characteristic feature. Now, alkalosis occurs when there is excess base, and this when there is addition of this excess amount of base, and the base excretion is defective, right? So, there can be three cases: either excess base is added, either base excretion is defective, or acid is lost. Now, all these will lead to an excess of bicarbonate, so that the ratio it becomes more than 20. Now, what are the important causes and findings? We have already seen the causes and findings of metabolic acidosis in our previous sections. Now, just to have a recap, there are several types of metabolic alkalosis. The first type is chloride responsive alkalosis and or contraction alkalosis. Okay? So what is chloride? What is the cause of chloride responsive alkalosis? It is prolonged vomiting or nasogastric suction, and there is the urine. In case of chloride responsive alkalosis, urine chloride level goes below 10 millimoles per liter, and hypovolumic volemia is seen, and increased loss of chloride, potassium, and hydrogen ions are seen. Now, second type is your contraction alkalosis, where upper GI, which is caused by upper GI obstruction. Okay, so upper part of gastrointestinal tract gets obstructed, and here the changes that can be seen would be increased reabsorption of sodium with bicarbonate, loss of hydrogen and potassium, hypokalemia, which will lead to alkalosis due to hydrogen and potassium exchange, and chloride is reabsorbed along with sodium. Hence, the urine chloride level is low. Now, alkalosis responds to administration of your sodium chloride. Now, the next type would be your loop diuretics. What is the cause for this loop diuretics? Basically, there is blockage in reabsorption of your sodium potassium chloride, and these are most important are anions. and cations. So the changes that would be seen if there is the case of loop diuretics is there will be aldosterone secretion, which occurs causing sodium retention and wastage of sodium and hydrogen. Now, the next thing will be next type will be your chloride resistant metabolic alkalosis, which will have the causes as mineralocorticosteroid excess, primary and secondary hyperaldosteronism, glucocorticoid excess, Batter's syndrome, and Cushing's and adrenal tumor. Now, the changes that could be seen are urine chloride level. It will go above 20 millimoles per liter. Defective renal chloride reabsorption can be seen associated with underlying cause where excess mineralocorticoid activity results in increased sodium retention with wastage of sodium and potassium ions at the renal tubules. Now, next metabolic acidosis type can be your exogenous base. Here, the cause could be your intravenous bicarbonate, massive blood transfusion. Your antacids can cause exogenous base. Your milk alkali syndrome, your sodium citrate overload. So the changes that can be seen is excess base will enter the body or potential generation of bicarbonate from the metabolism of organic acids like lactate, your keto acids, citrate, and your salicylate. Okay. Now, since we have talked about the underlying types and their causes, let's say let's further get into metabolic alkalosis. Here, in case of metabolic acid alkalosis, loss of acid may result from severe vomiting or gastric aspiration and leading to loss of chloride and acid. Therefore, hypochloremic alkalosis will result. And hyperaldosteronism causes retention of sodium and loss of potassium. And in case of hypokalemia, it is closely related to metabolic alkalosis. And in case of alkalosis, there is an attempt to conserve hydrogen ions by kidney in exchange for potassium. So this potassium can lead to hypokalemia. Now, potassium from extracellular fluid, it will enter the cells in exchange for hydrogen. So in alkalosis, pH of urine remains acidic, and hence this is called paradoxic acidosis. What is now subclassification of metabolic alkalosis? So let's talk about subclassification. It can be chloride responsive, either chloride responsive or it can be chloride resistant. So what is chloride responsive? Basically, this condition is basically in this condition, basically urinary chloride is less than 10 millimoles per liter. So it is seen in case of prolonged vomiting, nasogastric aspiration of, or administration of diuretics, and secondly, in case of chloride resistance, conditions like urine chloride is greater than 10 millimoles per liter. So it is seen in case of hypertension, aldosteronism, severe potassium depletion, and Cushing's syndrome. So, due to exogenous base, which is often heterogenic, now what will be the clinical presentation in the case of metabolic alkalosis? What will be your patient looking like in case of metabolic alkalosis? So here in that case, if the respiratory center is depressed by high pH, leading to hypoventilation. Okay, so it would result in accumulation of carbon dioxide, and it will attempt to when carbon dioxide will be accumulated, it will lower down your HCO3 minus carbonic acid and bicarbonate ratio levels. So now, however, the compensation is very limited. So by hypoxic stimulation of respiratory center, so that the increase in PaCO2 is always above 55 mmHg. Now, the renal mechanism, it is more effective when it conserves hydrogen and excretes more bicarbonate. Now, however, complete correction of alkalosis will be effective only if potassium is administered and the cause is removed. Now, there is a increased neuromuscular activity, which is seen in when pH is above 7.55, and alkalotic kidney results when the presence of normal serum calcium, when there is presence of your normal serum calcium. Now, in your case of metabolic alkalosis, maximum limits of compensation PCO2, it can go up to 50 of Hg. Okay, and the various causes of metabolic alkalosis, the reasons why metabolic alkalosis will be caused, will be maybe first of all in case of your severe vomiting. So in case of severe vomiting, there is excess release of your ions, anions, and cations. So it will may lead to metabolic alkalosis. Second is your inborn error, that is your Cushing syndrome. Okay. The third one is your milk alkali syndrome. Next will be your diuretic therapy, where there is loss of your potassium. Okay. Now, this was all about your metabolic alkalosis. Now, in our next sessions, we'll be talking about respiratory acidosis and your respiratory alkalosis. So, since this is over, you have to read completely about acidosis and alkalosis along with their normal values, their causes, their types, and changes which are seen in various types of or in cases of various causes of various pathological conditions. So this is it for today. I'll be looking up to you in your next session. And until then, if you have any doubt related to this session, you can always contact me. And until then, take care.